For a comprehensive examination, careful auscultation of both front and the back of the patient's chest is required. Major lung sounds are of two types: normal lung sound or the abnormal adventitious lung sound. Normal lung sounds are normal breath sound. It was previously known as vesicular breath sound, tracheal breath sound, or bronchial breath sound. Adventitious or abnormal breath sounds are crackles, which are of two types: fine crackles and coarse crackles, wheeze, rhonchi, stridor, pleural rub. Normal lung sounds are categorized as normal breath sound, tracheal breath sound, or bronchial breath sound. Normal breath sounds were previously termed as vesicular breath sounds. This is a misnomer because it was incorrectly assumed that breath sounds were produced by movement of air into the alveoli, and the alveoli is also known as vesicle. But now it is clearly known that air enters the alveoli via the diffusion, which is a silent process. Instead, inspiratory component arises from the sounds generated by turbulent airflow within the lobar and the segmental bronchi, whereas the expiratory component arises within the larger airways. During the normal breathing, inspiratory sounds are louder, expiratory sounds are softer, even inaudible. Compared to inspiratory sounds, expiratory sounds are softer because the sounds are generated in the larger, more central airways, where they are dampened by the large volume of the lungs air spaces. This is how normal breath sounds are heard. Tracheal breath sounds are tubular, non-musical sounds, heard in the both phases of the respiratory cycle. Their frequency patterns resembles white noise. Tracheal sound is best heard below the suprasternal notch. Auscultation of the tracheal breath sounds implies open central and the upper airways. Bronchial breath sounds are loud, medium pitched, tubular sounds. They are as loud as or louder during the expiration as during the inspiration. When the lung parenchyma is consolidated, bronchial sounds are well transmitted to the chest wall. Thus, the bronchial breath sounds becomes audible in the peripheral areas. Bronchial breath sounds are similar to tracheal breath sound, but their presence in the periphery is a classical auscultatory sign of consolidation. These are seen during the pneumonia, pulmonary edema, or hemorrhage. Detecting bronchial breath sounds indicate that the airway to the region is patent. The sounds originate centrally at the trachea and reach the chest wall only through the amplification within the airways surrounded by consolidated lungs. This is how the bronchial breath sounds are heard. Bronchovesicular breath sounds are in between the bronchial and the vesicular breath sound. It is of medium in loudness, intermediate in pitch, and it is heard over peristernal and the interscapular region. This is how the bronchovesicular breath sounds are heard. When the bronchial or the bronchovesicular breath sounds are heard over the areas of the lungs where it is not supposed to be heard, then the causes are collapse, consolidation, carcinoma, or cavity. These can be memorized by mnemonics 4C. The lung sounds originate at the central airways and we heard it over the chest wall. So the sound transmission may be attenuated or interrupted in certain conditions. Normal breath sounds are diminished or absent over a pleural effusion, pneumothorax, peripheral bulla, or distal to a obstructing mass, and these sounds may be increased in chest wall deformity or the bronchial or the tracheal derangement that allows the movement of air to the closer than the usual to the stethoscope. Abnormal breath sounds generally have a strong expiratory component, loud expiratory sound that raises special concern, and their type and the origin should be clarified. First one is the crackle. This is how it is heard. This is of mainly two types, fine crackles and coarse crackles. Crackles are also known as rels in the United States or the crepitation in the Great Britain. It is a series of short, explosive, non-musical sound that punctuate the underlying breath sound. Fine crackles are softer, shorter in duration, and higher in pitch than the coarse crackles. The small airways get closed due to the surface forces within them, and when there is explosive opening of this closed small airway occur that give rise to the pop sound, which is the characteristics of fine crackles. Crackles, therefore, are best heard during the first deep breaths at the lung base posteriorly. After several such breaths or intentional coughing, these fine crackles will disappear if the small airways remains open throughout the time of the patient being examined. Coarse crackles are low frequency sound that indicate intermittent airway opening, such as found with secretions. Coughing or deep inspiration may also change the quality of the coarse crackles, but the coarse crackles rarely disappears entirely. Now let's listen the fine crackles and the coarse crackles together. The American Thoracic Society Committee on Pulmonary Nomenclature has defined the wheezing as a high-pitched continuous adventitious lung sound that has dominant frequency of more than 400 Hz. Continuous sounds are longer than 200 milliseconds in duration. Wheezes are usually louder than the underlying breath sounds. Wheezings are produced by fluttering of airway walls and the air together. The pitch of the wheeze is depend on the mass and the elasticity of the airway walls and the flow velocity. The degree of the bronchial obstruction is proportional to the amount of the respiratory cycle it occupies. There is no relationship of the intensity or the pitch of the wheeze and the pulmonary functions. Wheezes are well heard over the trachea, and listening over the trachea may be superior to the listening over the lung in the most of the asthmatic patient. Wheezing with forced expiration can be sometimes be provoked in the healthy subject, and it does not establish a diagnosis of asthma. A more specific technique for detecting pathological wheeze is to elicit a wheezing and or coughing without forced expiration by having the patient breathe slowly to end expiration. This is how it is heard. Rhonchi are low-pitched continuous sounds with a dominant frequency of approximately 200 Hz or less. These sounds are likely to originate from rupture of fluid films and the airway wall vibrations. Rhonchi may clear with cough or with suctioning in intubated patients. This is how it is heard. Stridor is a high-pitched continuous sound produced by turbulent flow in the extrathoracic airway, which is louder and longer during inspiration than expiration. Stridor may have causes, some of which are life-threatening and that demand immediate attention. The common causes of stridor in adults are benign or malignant upper airway tumors, vocal cord dysfunction or paralysis, goiter, epiglottitis, laryngeal edema, laryngostenosis or subglottic stenosis, post-extubation edema, granuloma, deep neck infections like Ludwig's angina, anaphylaxis, and obesity. This is how it is heard. When the stridor is audible only in the inspiratory phase, then the cause is extrathoracic obstruction. Examples are laryngomalacia, vocal cord lesions. And when the stridor is audible only during the expiratory phase, the causes are intrathoracic obstruction. Examples are bronchomalacia, tracheomalacia, any external compression. And when it is heard over the both the phases, That means during the inspiration and the expiration, then it is due to any fixed obstruction like tracheal stenosis. The small amount of the fluid normally present in the pleural space that separate the visceral layer and the parietal pleural layer. This small amount of the fluid allows the lungs to expand and the contract freely during the breathing. When there is inflammation or any neoplastic process occur in the pleura that causes pleural surface thickening, that impair the sliding of the pleural layers, that produces pleural friction rub. The sounds vary in intensity but often have leathery or the cracking quality that may be exaggerated by pressure with the stethoscope. Typically, rubs are hard during both inspiration and expiration. This is how it is hard. The terminology rub implies that the friction between the pleural surface generates the sound. In actually, rubs may be generated simply by the change in the shape of the thickening of the pleura itself. Because a small amount of the fluid is always present between the pleural surface that prevent their direct contact. This would also explain why rubs are occasionally audible even in the presence of large pleural effusion.